بسم الله الرحمن الرحيم. Assalamu alaikum. The lecture of today will be about important and common neonatal problem, which is neonatal jaundice. At the end of this lecture, you should be able to know what is the significance of neonatal jaundice. Why do we need a study to the problem of neonatal jaundice? Why do we need to concentrate on this problem? And how can you evaluate a neonate with jaundice from clinical points? And of course, we should be able to manage the cases of neonatal jaundice. Let's discuss these cases briefly of neonatal jaundice, and we want to know the management of these cases. The first case is 8 hours old, full term. Total serum bilirubin is 200 millimole. It means 12 milligram per deciliter. Second one is 2 days old, full term. Total serum bilirubin is 283 millimole per liter or 17 milligram per deciliter. Third one is 3 days old with total serum bilirubin of 200 millimole per liter. It means 12 milligram per deciliter. The answers will be left to the end of lecture. This is another question for you. 4 hours old neonate is presented with total serum bilirubin of 100 millimole per liter or 6 milligram per deciliter. What could he have? What is a provisional diagnosis of this problem? Again, you can answer this question at the end of the lecture. Now we will talk about neonatal jaundice. Why it is common problem? Because the frequency it affects around 60% of all newborn infants. Full term. For preterm, this percentage is more, may reach to 80%. Why do they develop jaundice? Because hemoglobin falls rapidly in first few days after birth, and 1 gram of hemoglobin can result in 35 gram of bilirubin. And if we know the metabolism of bilirubin, we can understand more the problem of neonatal jaundice. Heme is converted to biliverdin. Biliverdin will convert to bilirubin. Of course, every step has certain enzyme. Then bilirubin will bind with albumin, forming bilirubin-albumin complex. This is in the liver. Then transported through the hepatocyte by carrier-mediated process, and then conjugation occur by the enzyme glucuronidase transferase. Then excretion through bile, through intestine, and through renal, either urobilinogen or stercobilin. And when it is conjugated in the liver, can go to the intestine, and from intestine to liver, we call it enterohepatic circulation. This is a picture of metabolism of the bilirubin. Again, this is another picture demonstrate the things we mentioned about metabolism of bilirubin. This is heme with globin This is hemoglobin in the extracellular fluid, and the reticuloendothelial system will be converted to biliverdin, then bilirubin, then in the liver conjugation occur, then excretion through intestine and kidney. And this is what we call it enterohepatic circulation. So after knowledge of this bilirubin metabolism, we can know why neonatal jaundice occur. The red cell lifespan of a newborn is around 70 days. It is shorter than that for adult, which is 120 days. So hemolysis occur quickly. In addition to that, the hepatic bilirubin metabolism is less efficient. So the metabolism of the liver, the conjugation in the liver, is immature in first few days of life. Why it is important? The significance of neonatal jaundice is coming from its association with other problems like infection. When the neonate is jaundice, he may have infection. The jaundice may be a sign of sepsis. And if you remember from the lecture of sepsis, we mentioned that one of manifestations of neonatal sepsis is presence of jaundice. Another significant point related to bilirubin that unconjugated bilirubin can be deposited in the brain, particularly in the basal ganglia, and when it is deposited in the brain, causing what is called bilirubin encephalopathy, or what we call it Kernicterus. So, what do we mean by Kernicterus? It is called bilirubin neurotoxicity. May occur when the level of unconjugated bilirubin exceeds the albumin binding capacity of the blood. Again, you can remember the slide of metabolism of bilirubin. And we mentioned that there is conjugation in the liver. When the unconjugated bilirubin exceeds this binding capacity with albumin, the free albumin is fat soluble, not water soluble, and it can cross blood-brain barrier. And when it crosses blood-brain barrier, what will occur? A neurotoxic effect. And these are different degrees, maybe transient, maybe associated with catastrophic changes, and maybe associated with increased mortality rate. Clinical manifestations of Kernicterus early, they can present with lethargy and poor feeding. Later on, when it becomes severe, it may be associated with irritability and increase in the muscle tone, what we call it opisthotonus. And Kernicterus can be associated with serious sequelae like chorioathetoid cerebral palsy, learning difficulties, and sensorineural deafness. You can see this boy is suffering from neonatal jaundice, and he is now presented with cerebral palsy, motor deficit, he is unable to walk. One of the important objectives of the lecture today is how to evaluate a neonate with jaundice clinically. When the baby is coming to us in the neonatal care unit complaining of jaundice, what are steps should be done? First of all, we should remember that the jaundice become clinically obvious when the bilirubin reach around 5 to 7 milligram per deciliter. And when we are sure that this patient or this neonate has jaundice, we should assess and manage according to different clinical points. We need to assess gestational age, the age of onset of jaundice, And what is the bilirubin level? What is the rate of increasing this bilirubin? And also we need to evaluate the neonate overall. What is the clinical condition? We should examine whole systems. And let's discuss these points separately. The first point is age of onset. So this is obtained from history. We can ask which age this jaundice started to occur. And when it occurs first day of life, less than 24 hours of age, usually it is pathological. Usually results from hemolysis. And one of the most common causes of pathologic jaundice in first day is Rh incompatibility. When the mother is Rh negative and the baby is Rh positive, this condition is developed. Why this condition developed when the mother is O negative or blood group negative and the baby is positive? During pregnancy, the red blood cells from unborn baby can cross into the mother's bloodstream through placenta. During birth or if abortion occurs during abortion, if the mother is Rh negative, the immune system regards these positive cells foreign body and antibodies will be formed against these cells. So these called Rh antibodies again will cross through placenta into the baby and causing destruction or hemolysis of the RBC. This Rh incompatibility does not occur in firstborn babies because still the mother is not sensitized. No antibodies, or the antibodies is still not in the quantity sufficient to destruct RBC. Rh incompatibility can be identified antenatally, it means during pregnancy, and there is therapy, maybe fetal therapy, transfusion, fetal transfusion, or fetal exchange. When the newborn is delivered, he may have some clinical manifestations like anemia, high drops, and hepatosplenomegaly. This patient or this neonate is presented with anasarca. You can look to edema of the face, all body. He has anemia, jaundice, hepatosplenomegaly. There are other causes of jaundice that may occur in first day of life. ABO incompatibility. The ABO incompatibility is more common than Rh disease. When the mother blood group of the mother is O positive and the baby is A or B, this problem can occur. Most ABO antibodies are IgM and don't cross the placenta, and some group O women have Ig anti-A and IgG anti-B hemolysin antibodies. These antibodies with RBC of the baby can cause hemolysis with antigens that are present on the RBC of the baby. But the hemolysis with ABO is less than that of Rh incompatibility. Hemoglobin is normal or slightly reduced. No hepatosplenomegaly. Coombs test is weakly positive, while it is positive in Rh incompatibility. And it can occur in firstborn babies because I mentioned that the mother has anti-A and anti-B hemolysin. It does not become more severe in further pregnancies. There are also other causes that be associated with jaundice in the first day of life, like G6PD deficiency and spherocytosis. Also, other causes of jaundice in first day of life: congenital infection. And these are pictures of baby who are born with the clinical manifestations of congenital infection, like rash, hepatosplenomegaly, anemia. This is another picture of babies born with congenital infection. We are still focused on the first point in assessment of neonatal jaundice, and we mentioned that the day of onset of jaundice. If the jaundice starts from 2 days after 24 hours, from second day to 2 weeks of life, we put physiological jaundice as important cause to be differentiated than pathological cause. Here, jaundice is attributable to a physiological immaturity of a neonate, because the neonate cannot deal with bilirubin production, and it is appear after first day to 3 days of life. And the total serum bilirubin rise is not more than 12 to 15 milligram per deciliter. The peak is in 3 days, then fall later on. In preterm occurs on 3 to 7 days, and total serum bilirubin may rise over 15 milligram. It may take weeks before total serum bilirubin falls under 2 milligram per deciliter in both term and preterm baby. To diagnose this, we should exclude other causes of jaundice. There is another cause of jaundice after 24 hours, breastfeeding jaundice, either result from inadequate breastfeeding when the mother is presented with delayed starting feeding, or she gave infrequent breastfeeding. This will increase enterohepatic circulation, leading to increased jaundice. Again, you need to review the slide of bilirubin metabolism to know that increasing enterohepatic circulation can cause increase in the bilirubin. And there are many problems behind breastfeeding problems. Example: improper positioning, improper attachment, cracked nipple, engorgement. Sometimes the mother is not giving her baby frequent feeds. And breast milk jaundice need support to the mothers, and we should know the way of breastfeeding, proper positioning, proper attachment, adequate measures to address breastfeeding problems. There is another condition also due to breast milk called breast milk jaundice, not due to inadequate breast milk as in the previous slide, but the problem with conjugation. Breast milk sometimes is associated with defect in the conjugation of the liver due to unknown factor, but this is a benign condition, can resolve spontaneously, and we should encourage mother for continuation of breast milk. There are other causes of jaundice like infection. During infection, unconjugated form of bilirubin can occur due to poor fluid intake. Again, the enterohepatic circulation is increased. Decreased hepatic function also behind the cause of jaundice in infection. Example of infection: urinary tract infection. There are other causes like bruising, polycythemia. This is increased load of the RBC that is associated with increasing in the bilirubin. And also there is condition called Crigler-Najjar syndrome. The problem is with glucuronidase transferase deficiency. If the jaundice prolonged after 2 weeks of age, it is called persistent neonatal jaundice. And unconjugated type, mainly due to breast milk jaundice, which may last for 1 month, and sometimes due to infection by urinary tract infection mainly. And one of the important causes of persistent neonatal jaundice is congenital hypothyroidism. This is a picture of baby complaining of congenital hypothyroidism. Again, we will continue talking about the assessment of neonatal jaundice. We talk about the first point, which is age of onset of jaundice. The second point is severity of jaundice. What is the level of jaundice? First, we need to measure total serum bilirubin. And in the beginning, the jaundice observed in the head, face, then started to spread down the tract and limbs. Of course, the level should be checked, and we can conclude if the jaundice is involving whole body, it is severe. And the third important point that we need in assessment of neonatal jaundice is rate of change. The rate of rise tends to be linear until a plateau. It means it increase, then take a stable level, then start to decrease. This is the usual rise in the bilirubin. But when this usual character is changed and the rate become more, rough figures, when the level exceeds 6 mg per deciliter in the first 6 hours and 10 mg in the first second hour, it is highly increased, and the rate is not more than 0.5 to 1 mg per deciliter per hour. So we can assess the age and the level, then the rate of increase of this bilirubin. Don't forget to assess the gestational age by history and by examination, because preterm babies are more susceptible to be damaged from raised bilirubin. So the intervention with them is lower than that for full term. It means the level for photo, the level for exchange is lower than that used for full term baby. We mentioned in the beginning, we need to examine this baby full examination. After taking history from the mother, after concentrating on the point we mentioned, then we need to examine the baby, because some factors are present during examination or during assessment of this baby can lead to an increase in the serum bilirubin. For example, hypoxia. If the baby has respiratory distress, for example, we need to check body temperature, hypothermia, any serious illness, sepsis, pneumonia, urinary tract infection. Those infants are susceptible more to damage from severe jaundice. And we concentrate on drug history, because some drugs displace bilirubin from albumin. Examples, sulfonamide and diazepam. So they are rarely used in a newborn period. In the management of neonatal jaundice, we need to concentrate on the points that may increase the jaundice, like poor milk intake. We encourage breast milk regularly, frequently, on demand, and encourage feeding from breast at night. Dehydration is associated with increased jaundice. There is old idea of feeding glucose water. This is associated with increased jaundice, not decreased jaundice. So the most important feeding is breast milk. Delayed feeding or inadequate feeding increase enterohepatic circulation, and when the enterohepatic circulation is increased, bilirubin is increased. And this slide can show to you the causes of hyperbilirubinemia in a newborn. There are two important problems. Either the bilirubin is increased or decreased bilirubin clearance. It is present, but the clearance of this bilirubin is decreased. Increased bilirubin either from hemolysis, and here are the causes for hemolysis, or from polycythemia, or from extravasation like kefal hematoma, or from DIC and sepsis. Decreased clearance of bilirubin occur in many problems like prematurity, increased enterohepatic circulation, inborn error of metabolism, and some hereditary problem, Gilbert and Crigler-Najjar syndrome, and hypothyroidism. So this is in summary. Either the bilirubin is increased or clearance is decreased. This is summary of lab investigations done for neonatal jaundice. If it occurs in first day of life, we need to evaluate for pathologic condition, congenital infection, and RH or ABO incompatibility. If it occurs after first day to 2 weeks, we need to do fractionation of bilirubin. It means direct and indirect. If the direct bilirubin is present, we evaluate for causes of defect in the bilirubin metabolism. This is not our subject. If it is mainly unconjugated, and this is the subject of talk of today, we need to assess hemoglobin. If the hemoglobin is normal, we need to assess either normal or low, assess reticulocyte count. If retic is increased, there is hemolysis. If hemoglobin is increased, it means there is polycythemia. And if bilirubin is persistent after 2 weeks, we need to assess fractionation. It means direct and indirect, and look for these causes that are mentioned in the slide. So this is the summary of investigations. There are 2 ways of treatment according to the level, according to the assessment of condition, either phototherapy or exchange transfusion. This is photo, this is set for exchange transfusion. This is a picture of photo, this is baby, this is phototherapy. This is picture of exchange transfusion, this is umbilical catheterization, this is donor blood, and this is blood which was withdrawn from the baby. Phototherapy is a light of wavelength 450 nanometer from blue band. It converts unconjugated bilirubin by photodegradation into harmless water-soluble pigment. There are 2 types, or really 3 types of phototherapy according to its intensity. Standard photo, the irradiance 8 to 10 milliwatt per square meter per nanometer. And intensive irradiance is more, reaching to 30 microwatt per square meter per nanometer. And there is what we call it double phototherapy. We use blanket, the baby lie on it, and over his head there is another light. This is called intensive double phototherapy. The intensive is like capsule put inside the baby. All the bodies is exposed to phototherapy. This is more in its effect. Of course, the eyes should be covered in every type of this phototherapy. It may be associated with hypothermia because the baby is put under the phototherapy naked. A hyperthermia, a dehydration, rash, and diarrhea. And sometimes there are some metabolic complications like hypocalcemia and hypomagnesemia. These are fluorescent lamp. This is old one of phototherapy. This is a new phototherapy. This is infant with eyes are covered, light under a new blue phototherapy. And also he is lying on a blanket which is fiber optic. This is double intensive phototherapy. This is another type of photo called Ahmeda halogen lamp. Observe that eye protection should be present. This is a blanket. We put the baby on it. LED phototherapy bed. This baby is put inside capsule. This is intensive photo. The effect of it is more than that of standard. Again, this is extensive photo. This diagram shows to us the guidelines for phototherapy. This is the level by milligram, and this is the age, and this is the zones of phototherapy classified into infant with low risk. This is infant with medium risk, and this is infant with low risk. Another modality of treatment for severe cases of hyperbilirubinemia is exchange transfusion. And exchange transfusion is required if the bilirubin rises to levels which are considered dangerous. Dangerous may cause bilirubin encephalopathy, especially if present with anemia. And the procedure is done via umbilical venous catheter. We draw 10 to 20 ml and replace them with donor blood. The blood prepared is 80 ml per kg, twice infant's blood volume. And this blood should be fresh, warm, and screened for some infections like cytomegalovirus, hepatitis B and C, and HIV infection. Really, no bilirubin level is known to be safe or which cause Kernicterus. In hemolytic disease, Kernicterus usually prevented if the level is below 20 milligram. This is for full term, and this reading may be lower for preterm. And we should know the indications of exchange transfusion: when there is hemolysis, when there is severe anemia, when the rise is rapid in total serum bilirubin, more than 1 milligram per deciliter per hour, less than 6 hours. All these are indications for exchange. A newborn with non-hemolytic jaundice, if intensive phototherapy fails to lower the bilirubin level, it is in need for doing exchange transfusion. And this is diagram showing the bilirubin level which is risky. This is bilirubin level, and this is the age by hours. And these are zones. This is low, this is high, this is medium. These called incentile, expressed as incentile chart. And there are many complications behind the procedure of exchange transfusion. Some of these complications are acute, like transient bradycardia, apnea, cyanosis, and transient vasospasm. And some of these are late, may occur later on, even after years, like infection by cytomegalo, HIV, hepatitis, and necrotizing enterocolitis, anemia, cholestasis, graft versus host reaction, inspissated syndrome, and portal vein thrombosis. This may occur even after years. So, in conclusion, we know what is meant by jaundice, what is the significance of jaundice, what are the causes of jaundice, how to evaluate a neonate with jaundice. So, now it is easy for us to answer the questions that are written in the beginning of the lecture, and you can also answer this question. If you meet 3 days old neonate with jaundice and the mother gave history of starting jaundice in first day of life, and this baby is in need for exchange transfusion, the exchange was done for him. The question is, what is possible positive findings in his family history? This is another question. Again, simple, you can answer. What is your advice to mother when she is coming with blood group O positive and she delivered baby with A positive blood group? This is another question. Again, it is easy. 3 days old neonate is come with jaundice. Total serum bilirubin is 13.2 milligram per deciliter. This baby is full term. On examination, he has normal finding. So, what was your answer regarding the management of this neonate? So, any management depends on the points. Remember the points that you need in assessment, then you can conclude the cause, then you can manage. Thank you very much for listening.